You have a wonderful speaker, Professor P K Sasidharan. He's one of the best speakers in medicine in Kerala State today, and the past president of the APA Kerala chapter. Dr. Sasidharan, please. The floor is yours.
Thank you, Chairperson. It's an honor to be invited for this talk, but it's not a favorite topic of mine. It's very common to come across electrolyte imbalances in pregnancy, and these are the reasons why it becomes important. Universally, it is very common to see electrolyte imbalances, especially in pregnancy. Normal values differ in pregnancy, and pregnancy has added risk due to the imbalances. Some causes are unique to pregnant state, and risk happens both to the mother and fetus. Therefore, prompt recognition, correction, and prevention are very important. These 5 aspects I will focus on. Before we come to the electrolyte imbalance, it is very important to know the hormonal changes in pregnancy and their influences on electrolytes. Estrogen that is secreted from placenta and ovaries increase hepatic angiotensinogen, leading to increased angiotensin. Consequently, increased aldosterone from the adrenal cortex is released, and which leads to sodium retention, increased plasma volume, and increased potassium excretion. Estrogen stimulation estrogen release from the placenta increases cortisol from adrenal cortex, which also enhances sodium retention and potassium loss. Posterior pituitary osmostatic is reset. It releases ADH at a lower osmotic threshold, and under the influences of that, water retention happens and there is dilutional hyponatremia. Progesterone has a protective effect. In fact, it leads to smooth muscle relaxation, increase of renal blood flow, and it enhances mild natriuresis, and it also acts as a mineralocorticoid antagonist at a receptor level. The HPL, human placental lactogen, which has growth hormone-like effect, has an anti-insulin effect also, can modify potassium shields. This is a gross hormonal change that happens which influence electrolytes. And this is in summary: increased RAS activity, renin-angiotensin aldosterone system leads to excessive sodium and water retention. The plasma volume goes up to 40 to 50% higher than normal, higher than the pre-pregnant state. Progesterone's anti-mineralocorticoid action partially protects against potassium loss and prevents excessive sodium retention. The ADH reset at a lower threshold leads to the mild hyponatremia. It is like the syndrome of inappropriate ADH secretion like situation. Fall in plasma osmolality up to 10 milliosmol happens due to the reset threshold, and increased GFR and renal blood flow is because leads to increased filtration and loss of magnesium, phosphate, and other solutes in plasma. This much of fluid is retained in a normal pregnancy, almost 6 to 8 liters of additional water in normal pregnancy. Fetus placenta amniotic fluid around 3,500 ml. Maternal blood volume increases by 1.5 to 1.56 liters, and in the mother at the uterus, breast, intracellular fluids altogether 3.5 liters. This much fluid increase occurs during a normal pregnancy. And this increase is distributed according to the usual proportions: 55% of fluid, 45% solid in a female, and out of which 2/3 is intracellular, 1/3 is extracellular, and out of the extracellular, 80% is interstitial, 20% is plasma volume. So all this proportionately increased, and it is distributed evenly, and there is no edema. These are net effects on major electrolytes. Serum sodium decreases by 5 millimole due to the increase in total body water, but there is no edema because it is distributed into intracellular and extracellular compartments evenly. Potassium usually is normal in spite of the aldosterone promoted potassium loss, but it remains low normal. Calcium also is total calcium is slightly decreased, but ionized is kept normal. Magnesium also there is mild decrease because of the increased urinary loss due to the increased EFR. Phosphate also falls slightly. Bicarbonate falls because of the compensatory response to mild respiratory alkalosis. There is a physiological hyponatremia. The normal value of is usually 130 to 135, not 135 to 140. So values below 135 require search for pathological causes by detailed history, clinical examination, and relevant investigations. 130, less than 130 sodium levels are not enough to diagnose hyponatremia. We need clinical evaluation also. We need to predict the possibility of developing hyponatremia by studying the situation. Is there a clinical situation which can lead to contribute to hyponatremia? Is the patient symptomatic or not, like encephalopathy, coma, seizure, or muscle cramps? And if there is hyponatremia, is it hypovolemic, euvolemic, or hypovolemic? These three we have to differentiate. Hypovolemic means due to fluid loss, salt loss, especially that happens in diarrhea, vomiting. Euvolemic means SIADH situations, which their fluid is retained, but it goes into the intracellular as well, and there is no edema. Though water is retained, there is no edema. There is a proportionate increase in free water in the plasma leads to hyponatremia. Hypervolemic means edematous states. This happens in patients with incidental development of renal disorders, congestive cardiac failure, or hypoproteinemia due to multiple reasons. And this is one which we might come across, especially during pregnancy. Poor intake is very common due to the first trimester anorexia, nausea, and diarrheas can occur, incidentally occurring diarrheas like colitis. And rarely some patients may be having adrenal insufficiency pre-existing or during pregnancy due to Sheehan syndrome, or sometimes they may receive diuretics, and this can lead to the hypovolemic hyponatremia. Euvolemic is syndrome of inappropriate ADH secretion, usually happens in the setting of preeclampsia, eclampsia, or incidentally developed CNS disorders like cerebellar thrombosis, meningitis, or other things, and even pulmonary infections like pneumonia. Medications which can produce ADH-like situation is excessive oxytocin, because the structure is similar. Oxytocin and ADH are structurally similar. SSRIs, medications like carbamazepine can also induce SIADH. These patients do not have edema, but excess water is distributed evenly into the intracellular and extracellular compartment. There is no edema, but there is hemodilution and hyponatremia. In euvolemic hyponatremia, this distribution is a reason. A proper distribution into the intracellular and extracellular compartment is the reason why they do not have edema. Euvolemic means they do not have edema. Actually, the total body water has increased. Water intoxication during labor is the commonest cause by hypotonic IV fluids. If you prescribe dextrose alone or hypotonic oral fluids alone, in the presence of excessive ADH, they might have hyponatremia due to euvolemic hyponatremia. Iatrogenic is due to 5% dextrose or other hypotonic solutions during induction or oxytocin infusion. Or pain-mediated increase in ADH can also be a cause for euvolemic hyponatremia due to excessive water retention. And during treatment also, hyperemesis and delivery, one should not be using hypotonic fluids in pregnancy to prevent this kind of hyponatremia. Rarely only endocrine causes like hypothyroidism can be a cause for euvolemic hyponatremia. Hypervolemic hyponatremia, fortunately, is rare. They may not be developing these problems, but if they have heart failure, hepatic dysfunction, nephrotic syndrome, they can have hypervolemic hyponatremia with edema in the limbs. But edema sometimes can be normally seen in pregnancy in the third trimester, but that has to be excluded. In preeclampsia also, in addition to the euvolemic hyponatremia, in patients with pregnancy, during preeclampsia or eclampsia, there is endothelial leak, capillary leak and fluid shift to interstitium and altered renal handling, they develop hypervolemic hyponatremia as well. So they have a combination of both. And postpartum causes are water intoxication due to continued oxytocin or inappropriate fluid therapy, or Sheehan syndrome developed during pregnancy, or secondary adrenal insufficiency of other reasons. The clinical features are known to all of us. Most patients are asymptomatic, and we often notice hyponatremia incidentally. And the symptoms depend on the rate of development of hyponatremia rather than on the absolute levels. If the patient from the normal of 135 falls down to 125 fast, they may become more symptomatic. But if it is a slow development over more than 48 hours, they may not be symptomatic. Rapid decrease causes symptoms like anorexia, nausea, vomiting, fatigue, lethargy, muscle cramps, sometimes headache, altered mental status, agitation, seizures, coma can occur. Anticipate neonatal hyponatremia in babies delivered to such patients. And the fetal impact is also important. Fetal distress, seizures, and even fetal death can happen in severe hyponatremia. So hyponatremia should not be neglected. It has to be identified and treated promptly. When you identify hyponatremia, look for whether the patient is dehydrated, in which case it is a hypovolemic hyponatremia. If there is no edema, it could be a euvolemic hyponatremia, which is very common in pregnancy. Or if there is edema, other than due to the physiological edema, due to the gravid uterus, it could be a hypervolemic hyponatremia. Peripheral edema has to be carefully evaluated in patients in the third time. Confirmation of hyponatremia is not just based on serum sodium alone. We should demonstrate that there is no other causes for the symptoms which we observed in the patient. Serum sodium obviously has to be less than 130. Symptoms are consistent, and there are no other causes for the clinical features we have observed. All these three are necessary to confirm hyponatremia in pregnancy. And the actions are decided by these levels and the clinical features. 130 to 135, asymptomatic, it can be considered physiological and observed only. 120 to 129, patient have symptoms. It is a moderate hyponatremia, needs treatment. Severe needs, they may have seizures and coma, it needs emergency care. Mild hyponatremia, no active correction, monitor serum sodium and clinical status, but avoid excessive free water. Moderate hyponatremia, that is 120 to 129, vomiting, volume depletion, needs isotonic saline, 0.9% saline slowly. But if it is SIADH with water intoxication, fluid restriction is very important. Fluid up to 800 to 1000 milliliter per day only. And if necessary, if it is a severe hyponatremia, sometimes low dose furosemide can be added to facilitate excess free water loss. Medication-induced SIADH stop the offending agent like oxytocin or SSRI. Severe symptomatic hyponatremia less than 120 with seizures and coma, it's a medical emergency. Treatment should be in the ICU setting. They need hypertonic saline. Others can be managed just with whatever may be the etiology, they can be managed by correcting the cause and normal saline only. Only severe hyponatremia needs hypertonic saline given as 100 ml IV over 10 minutes and may be repeated 3 times until symptoms improve. Then switch to controlled correction using continuous infusion or slowly, or even normal saline carefully can be used to maintain. But do not raise serum sodium rapidly to prevent osmotic demyelination. Only 4 to 6 millimole per liter in first 6 hours. Maximum 8 only. It's not more than that. Monitoring in severe cases, we have to monitor these things: sodium, strict intake-output chart, neurological status, and fetal monitoring. Specific situations are important. Hyperemesis gravidarum, IV normal saline, needs potassium replacement, avoid dextrose unless sodium is normalized, because they have a fasting state, and dextrose, if it is given prematurely, will lead to Wernicke's encephalopathy, especially without timing. So in that situation, give normal saline, potassium, and dextrose has to be started after that. Preeclampsia, eclampsia, fluid restriction, treat underlying disease, avoid excess IV fluids because there is oxytocin-induced ADH excess-like situation. Oxytocin-induced water intoxication, stop oxytocin, restrict fluids, hypertonic saline if it is severe hyponatremia. Adrenal insufficiency, anyway, steroid replacement, hypothyroidism, also thyroxine replacement. Hyponatremia prevention in pregnancy basically is achieved by avoiding excessive free water intake any time during pregnancy. Use only isotonic fluids, even with oxytocin, not hypotonic solutions like dextrose. Use only normal saline if possible, as far as possible. Monitor sodium in women with hyperemesis, preeclampsia, and prolonged labor. And proper dietary habits and management of risk factors are very important in these patients. Coming to potassium homeostasis, following a meal, potassium goes up, and in that situation, the mineralocorticoid effect of aldosterone comes, and it will eliminate it, and most of it goes into the intracellular compartment. Eventually, any excess potassium is excreted in urine. Renal potassium excretion and potassium balance occurs in the distal tubules, and it is regulated by aldosterone and hyperkalemia. Whenever we eat potassium-containing food, the serum potassium rises. In response to that, aldosterone is released, and it will lead to potassium elimination. So changes in potassium during pregnancy, it's a state of increased aldosterone because of the increased RAS activity, and there is always a mild alkalosis which shifts the potassium into the intracellular compartment. So serum potassium is always kept at the lower limit of normal. Progesterone partially antagonizes the aldosterone effect. Hypokalemia in pregnancy is diagnosed when it is less than 3.5. But normal potassium does not rule out hypokalemia because this is because of the hemolysis. Or the pseudo hyperkalemia component in serum samples. So always low is low, but normal may not be normal. Always recheck by plasma potassium, and the causes you have to look for. Poor intake in the diet is sometimes a rare sole cause for hypokalemia in pregnancy because most patients may not be consuming potassium-containing vegetables and fruits. Further decrease occurs due to nausea, anorexia, and vomiting. And gastrointestinal loss becomes very common during the first trimester or when they develop illness like diarrhea. And use of laxative and the coexisting hypomagnesemia accelerates potassium loss. Hypomagnesemia worsens potassium loss. Excess intracellular shift is another cause. Like when you give insulin and dextrose, the potassium goes intracellularly. So that is another cause. And sometimes catecholamines, like asthma medications, can shift the potassium intracellularly. Alkalosis, especially the respiratory alkalosis due to the hyperventilation, can shift the potassium intracellularly. Insulin given will certainly shift. Increased urinary potassium loss occurs due to the hypomagnesemia, which is very common, and diuretic use, and rarely some patients may have mineralocorticoid excess as a disease also. Preeclampsia, hypokalemia is common due to several reasons, due to the RAS activation and hypomagnesemia, diuretic use, and in uncontrolled diabetes, osmotic diuresis itself is a cause for magnesium and potassium loss, and use of steroids and hyperthyroidism, if it is there, also is a cause for potassium shifts intracellularly, and certain drugs also may be a cause for hypokalemia in pregnancy. Symptoms, most of them are asymptomatic, with a 3 to 3.5 range, but if they are symptomatic, they have muscle cramps, muscle weakness, paraparesis, quadriparesis, Guillain-Barré-like presentation rarely can occur, fatigue, constipation can be a presentation, paralytic ileus in severe cases. They may have cardiac arrhythmias due to the hypomagnesemia and hypokalemia. Severe hypokalemia can even impair the renal tubules, resulting in polyuria. And respiratory muscle weakness can be dangerous in a pregnant woman with hypokalemia. It has to be corrected promptly. So diagnosis depends on clinical setting and the serum potassium. And if you are in doubt, repeat and get a plasma potassium, because serum potassium may be falsely normal due to the pseudo hyperkalemia component. If it is less than 3.5, it confirms, but not be happy with the normal values, repeat a plasma potassium, and check also for coexisting hypomagnesemia. Hypomagnesemia always coexists, and blood gas analysis, if indicated, especially if there is alkalosis, And urine potassium, in case you suspect a renal loss, ECG may show signs but do not depend on ECG for diagnosis. Treat the underlying cause and improve dietary intake. That is how we manage hypokalemia. Control vomiting, antiemetics in hyperemesis gravidarum, and stop or adjust the medications causing potassium loss or shift, like beta agonist in asthma, or insulin may be the cause. And we have to be cautious about when we're giving insulin, potassium shifts intracellularly. Avoid excessive use of diuretics and laxatives in pregnancy. That could be the cause for potassium and magnesium loss. Potassium replacement preferred route is oral, especially in mild and moderate cases. IV replacement in severe, symptomatic or cannot tolerate oral intake, but always monitor potassium levels regularly during replacement. Management of hypokalemia in pregnancies, continuous monitoring is needed to prevent cardiac arrhythmias. Fetal monitoring is important. Oral dose 40 to 100 milliequivalent in divided doses. Use potassium chloride preparations to minimize EA irritation, but give it only after food. It has to be diluted with water. Do not take it directly. Advise taking with meals and water to reduce the gastric discomfort. Intravenous potassium replacement in severe cases less than 2.5. Having symptoms like muscle weakness, arrhythmia, or when they are unable to take oral potassium chloride in severe vomiting, 10 to 20 milliequivalent in 100 ml normal saline given over 1 hour. Hypomagnesemia almost always coexist, and we have to correct it. And if you think hypomagnesemia is there, it has to be given intravenously, or we can give oral magnesium if they can take oral tablets. And hypomagnesemia is another problem that is very important in pregnancy, but very often an unrecognized electrolyte imbalance. They may have symptoms similar to hypocalcemia, like neuromuscular irritability, muscle cramps, tremor, even tetany. Though it is not a pregnant patient, recently I had a patient who came with unexplained involuntary movements. It was purely due to hypomagnesemia. Increased risk of seizures, especially in preeclampsia and eclampsia, is due to the hypomagnesemia, and it predisposed to cardiac arrhythmia, including prolonged duty interval and ventricular arrhythmias. There is increased risk of hypertension and preeclampsia severity if there is hypomagnesemia. Possible impact on glucose metabolism and insulin resistance, and may affect fetal growth and development also. These are the symptoms of hypomagnesemia. Early symptoms are weakness and fatigue, muscle cramps and twitching, paresthesia, that is numbness and tingling around the mouth, tremors, hyperreflexia, unexplained involuntary movements, tresocine, like acid-getting hypocalcemia, chaustrexine may be elicited in hypomagnesemia also. When you tap on the facial muscle, the twitching occurs. Tetany, seizures, cardiac arrhythmias in severe deficiency, personality changes, confusion, irritability, even seizures can occur. Diagnosis based on serum magnesium levels. More importantly, a clinical scenario to how hypomagnesemia. Decrease intake of vegetables and fruits is the number one clinical scenario. Vomiting effect is there, diarrhea is there, there is magnesium and potassium loss. So a clinical scenario assessment is more important, and measurement definitely confirms it. Serum calcium and potassium deficits always coexist along with hypomagnesemia. So all these need to be simultaneously corrected. Assess renal function to rule out an excessive renal loss, and ECG to look for prolonged duty interval. Urinary magnesium excretion may help differentiate renal losses if there are no other cause documented. Management is oral magnesium supplementation. You have magnesium tablets, magnesium oxide tablets, 200-400 milligram can be given in divided doses. Magnesium-rich food is very important in preventing and managing hypomagnesemia and hypokalemia, and even in hypocalcemia, because we need magnesium and potassium supplements available from vegetables and fruits that has to be taken regularly. And severe symptoms, symptomatic hypomagnesemia needs IV magnesium sulfate correction using typical doses 1 to 2 grams, diluted in 50 to 100 ml normal saline, infused over 1 to 2 hours. And hypokalemia and hypocalcemia, which is coexisting in hypomagnesemia, has to be corrected simultaneously. Treat the underlying cause for electrolyte imbalance, and that's very important. One of the most important condition that we come across is hyperemesis gravidarum in pregnant women. Initiate antiemetics such as ondansetron or metoclopramide promptly, and maintain hydration with IV fluids containing potassium if vomiting is severe. Use only normal saline initially. Do not use dextrose initially in these patients. Discontinue medications causing potassium loss like diuretics and laxatives. Monitor potassium and magnesium levels. Cardiac monitoring, and if severe hypokalemia or arrhythmia is noted, monitor urine output and clinical signs. Encourage potassium-rich food, that is magnesium-rich, potassium and magnesium-rich food, that especially vegetables and fruits, which is universally missing in the diet of Indians, not only pregnant women. Coming to hyperemesis gravidarum and starvation ketosis, which I have added because I noticed that brochure recently only. Body switches from carbohydrate and fat to protein metabolism. Actually, during fasting in hyperemesis gravidarum, fat and protein are utilized for calories. That's what happens in that state. It's a situation of severe starvation. Insulin secretion is very low. Intracellular stores of potassium, magnesium, and phosphate are depleted, and serum levels may be normal. Serum levels of these may be normal, but actually the body is depleted of all these. When feeding these patients, especially when the carbohydrate is resumed, insulin secretion goes up. This will further drive the potassium, magnesium, and phosphate intracellularly. That will lead to dangerous problems. So insulin drives the insulin surge drives of glucose, potassium, phosphate, and magnesium, and water into cells. And a sudden drop in phosphate during the rapid glycolysis, with a demand for phosphate because of the ATP synthesis goes up, so phosphate need goes up, and such patients need thiamine supplementation also when you give dextrose. So give thiamine before giving dextrose, and give dextrose only after giving sodium chloride, potassium, and magnesium correction. And gradual increase in caloric intake to avoid risk of refeeding syndrome. That is what happens in a patient with severe hyperemesis gravidarum. And coming to the last problem, hypocalcemia and pregnancy. They may have similar features as hypomagnesemia, paresthesia, numbness, tingling around the mouth and fingers, and muscle cramps, especially in calves, and fatigue, irritability, seizures in severe cases, cardiac arrhythmias, prolonged QT interval is common. Increased risk of preeclampsia is common in hypocalcemia, and the commonest cause of hypocalcemia is obviously vitamin D deficiency. And possible impact on bone metabolism and cardiac symptoms like palpitations and arrhythmia may be the presenting manifestations. These are some of the clinical features. Carpopedal spasm in severe cases, like the hand goes into the peculiar posture, and positive Trousseau sign or Chopstick sign. Tetany may be there in some, seizures in some. Very rarely, severe hypocalcemia can produce laryngospasm. I have not seen only one patient I think that was a hypoparathyroidism, but not in pregnancy. Patient came with a severe stridor. Rarely that can happen in severe hypocalcemia. Fetal impacts are impaired skeletal development, neonatal hypocalcemia leading to tetany or seizures, and potential intrauterine growth retardation. All these are problems due to hypocalcemia also. In diagnosis depends on serum calcium less than 8.5. Serum phosphate is calcium and phosphorus are low in vitamin D deficiency, and alkaline phosphate is obviously elevated, but elevated alkaline phosphate is non-specific in pregnancy. But anyway, if you get low calcium, low phosphate, it is definite vitamin D deficiency. Vitamin D levels can be checked, and parathyroid is estimated to know whether it is vitamin D deficiency or hypoparathyroidism. And the commonest cause for hypoparathyroidism again is hypomagnesemia. That is another point we have to keep in mind. People who do not take vegetables and fruits and having low magnesium will also have hypoparathyroidism. So all these go together. Magnesium replacement is important to improve calcium correction, monitor fetal well-being in severe and prolonged cases. Routine antenatal vitamin D and calcium supplementation is absolutely essential. Like 2000 units of vitamin D every day is the best ideal way rather than giving 60,000 units in massive doses. This can be given lifelong. In fact, there is no harm at all. And 1000 milligram calcium daily, adequate dietary calcium intake from natural sources, vitamin D containing proteins to be included. But people do not take vitamin D containing proteins including in pregnancy. The vitamin D containing proteins are curd, fish, meat, and egg. Mushroom also. But do not give milk for vitamin D. Early identification treatment of maternal vitamin D deficiency is important. And finally, an education on proper diet is very important before conception and during pregnancy. So coming to the prevention of these electrolyte imbalances, consuming a balanced diet at each meal should be started early before conception and throughout pregnancy. Keep the weight in desired limits before conceiving so that they do not get into the problems of preeclampsia, eclampsia. Prevent these conditions including gestational diabetes and hypertension if possible. Early diagnosis of complications and proper diet with medications including viral treatment is very important, which people forget even in the pregnant women. This is a proper diet they have to be following. The vegetables and fruits should be there every time they eat, not just carbohydrates and some additional protein in minimal amounts. This will provide most of these essential nutrients, including magnesium, calcium, potassium, and vitamin D together. This is the most important medication that they need throughout pregnancy, and that has to be advised. And good lifestyle habits also has to be given to them before conception and during pregnancy and in the postpartum period, so that they will not develop these electrolyte imbalances. Thank you.
Sir, I would like to ask a question. Are there any specific guidelines regarding fluid management in pregnancy?
I don't think there is any specific guidelines, but we should know that specific changes that happen in pregnancy and be aware of the excess volume in the body and be aware of the SADH situation, like fluid overload situation, and the low calcium, low levels of sodium, potassium, and calcium. So keeping that in mind, we need to manage them. Other than that, there is no specific guidelines in pregnancy. We should know that. That's why I dare to speak on this topic, because I have not managed electrolyte imbalance in pregnancy as such.
Sir, excellent presentation. Sir, I have one question to ask. Is there any role for steroids in refractory vomiting after the first trimester of pregnancy?
In the standard antiemetic protocol, in severe hyperemesis gravidarum, besides ondansetron, steroid also is recommended. It may be due to several reasons. It may be acting by several mechanisms. Some of these patients may be having a minimal hypoadrenalism-like situation due to some reason which may be undetected. I do not know how it acts. Maybe it may be acting on some inflammatory component, but I don't know how it acts, but it is recommended. Methylprednisolone is recommended, steroid in severe hyperemesis gravidarum.
Sir, it was an excellent presentation. I have a doubt. In hyperemesis, we are doing the serum electrolytes as a routine. But in induction of labor, we are not doing. You told there is sodium hyponatremia and magnesium like that. In routine practice, we are not doing these tests. Even in severe pH also, only once we will do. How often we have to repeat, because oxytocin induction will produce hyponatremia. What about
the person is totally, it is not diagnosed based on routine sodium or potassium or magnesium measurements only when a person is symptomatic. If the person is totally asymptomatic, I don't think you don't have to even monitor. I was talking about those with a deficiency and we going into induction level. There you have to monitor.
Routinely we are not doing all these things.
Not at all. It's not needed at all. We are talking about somebody who has developed a deficiency and then going into labor, then you have to monitor.
Any questions from the audience? No, if there are no more questions, we will give a good hand to Dr. Sasidharan. Thank you, sir.
Thank you, Professor P K Sasidharan, for that enlightening session.